Good afternoon, everybody. So today, Department of Neuroradiology is going to present a topic called Neurointervention in Trauma Beyond Direct CCF. So we are not going to focus on CCF, but there are other vascular lesions which are very common during the trauma. And how do we diagnose them? How do we treatment? That's the whole idea about presenting in the CGR. So Dr. Suraj will be presenting, taking us through the presentation. Thank you.
Thank you so much, sir. Today's topic is neurointervention in trauma beyond the direct keratocavernous fistula. There are various kind of trauma it can be iatrogenic, or RTA, or fall from the height. First, we'll see what is iatrogenic vascular injury. Vascular injury caused uneventually during diagnostic angiography, endovascular intervention, ENT, or skull base spinal surgery, tumoral biopsy or resection, or radiation therapy, post-radiation therapy. Why important for the neurointerventionist, these kind of iatrogenic injuries? Because they are often acute and life-threatening, required immediate angiographic diagnosis and endovascular therapy in first line in most of the cases. In iatrogenic injury, first we'll see the iatrogenic arterial injury, intracranially and distal ICA segment. In that also, the various kind of arterial injury scenarios, first will be the arterial dissection. The most common site of arterial dissection is cervical ICA, then the petrocavernous ICA, vertebral artery V1 and V3 segment, and intracranial ICA, M1 and basilar. Endovascular management of this arterial dissection, first will observe and put the patient on anti-thrombotic management, then the stent reconstruction management like self-expanding stent, flow diverters in selected cases. We'll discuss all these kind of cases later on. And then the parent vessel occlusion, PVO, if unsalvageable. Second scenario is the pseudoaneurysm, that is the false aneurysm. When the aneurysmal outpouching formed by less than the all three layer of the vessel wall, then it's called the pseudoaneurysm. The key features of this kind of pathology is delayed filling and emptying of that aneurysmal pouch, and they are very fragile, having very fragile wall and very high risk of rupture and causing profound bleeding. Endovascular option in this scenario, stent assisted coiling, cover stent in cervical segment in majority of the cases, and the flow diverter and the same parent vessel occlusion. Third scenario, active arterial extravasation or perforation. The management principle in this scenario, immediate reversal of the anticoagulants, balloon tamponade, coil or glue embolization, and same vessel parent artery occlusion. In this, first we'll see the first case of this presentation. This 33-year-old male presented with profuse epistaxis post ENT procedure. He came to our department and we performed diagnostic angiogram which revealed small pseudoaneurysm incorporating the paraclinoidal ICA, and this is the main bleeder site and causing the epistaxis. In this, we selectively cannulate that the aneurysmal segment via the microcatheter and put the balloon just distal to the neck of that aneurysm and perform the balloon assisted coiling. And subsequent check run revealed the complete obliteration of that aneurysmal part, and we planned, because this is a dissecting aneurysm, can rebleed after some time, so we planned for the elective flow diverter stent in later date. Second case, 25-year-old male presented patient suffering massive bleed post ENT biopsy. When he was presented to us, he was intubated and very anemic. Vitals are stable via the various drugs. We performed a diagnostic angio which revealed the leakage from the clinoidal segment of the left ICA. Then we perform the balloon assisted coiling in this case also. But because of the profuse bleeding, coiling was not sufficient. So at the end of the coiling, we also performed the embolizing. We also injected the embolizing agent within the sac to completely feel the rent site and the dilated venous pouch. After this only particularly arterial injury, another scenario is iatrogenic arteriovenous fistulas. The most common in this type of pathology, most common case is CCF, that is keratocavernous fistula. Can be caused by the ICA injury during the transsphenoidal surgery or skull-based intervention. Endovascular treatment are the gold standard management of choice in this case. Trans-arterial or transvenous coil embolization, the balloon assisted techniques or cover stent or flow diverter, or in very rare cases ICA sacrifice if necessary. Second type of this arteriovenous fistula example is dural AVFs, iatrogenic dural AVFs. The common causes are sinus injury during the surgery, accidental or radiation induced. The most common site for these kind of fistulas is transverse sinus junction, a transverse sigmoid junction, cavernous sinus, and the superior sagittal sinus. The management in this case, transverse sinus embolization, transvenous embolization, transarterial embolization via the onyx or squid material, and the sinus reconstruction via balloon or can be sacrificed if necessary. This is an example of that dural sinus fistula. Here we can see the post angiogram run revealed the sinus dural AVF involving superior sagittal sinus middle section, various feeders from bilateral ECA branches, that is the middle meningeal artery, and STA, that is superficial temporal artery from the contralateral side also, and the ethmoidal artery also from ethmoidal artery via the ophthalmic artery. In this, we selectively cannulate the one of the major feeder from the middle meningeal artery right side and continuously injected the onyx, which is the embolizing material. And then subsequently in second session, we did embolization via the left ECA, selectively cannulate the middle meningeal artery and embolize. Check angiogram revealed the complete obliteration of the fistulous site. Third, this iatrogenic vascular injury, third scenario is extracranial, basically access site extracranial iatrogenic injury in trauma, various kind of trauma. In this we have cervical pseudoaneurysm, subclavian pseudoaneurysm, and the vertebrovenous fistulas. First, the cervical pseudoaneurysm. The causes of this central iatrogenic causes can be central line insertion, carotid artery puncture in surgical injury, radiation induced vessel damage. The common vessels involved in this case like cervical ICA, vertebral artery, and the subclavian artery. Clinical presentation is majorly pulsatile neck mass with bruit and the some cases neurological deficit also, and the massive hemorrhage. Imaging finding, first CT angio revealed contrast field outpouching, outside field like bulging mass. Subsequently we performed DSA, which shows the narrowed neck, dilated, delayed washout aneurysmal pouch. Treatment options like cavernous covered stent is a treatment of choice. and the coil embolization also, and the parent vessel sacrifice. Advantages of the cover stents, like immediate exclusion of the aneurysmal pouch from the parent vessel, vessel preservation and the remodeling of the parent vessel, and the rapid hemostasis. In this pseudoaneurysm, first example case is a 45-year-old female presented with a post-traumatic dissecting cervical IC aneurysm. We performed the diagnostic angiogram, which revealed the wide neck dissecting aneurysm, giant dissecting aneurysm, which is a giant is more than 25 in size, incorporating the proximal ICA with dysplastic parent vessel. And this patient also having most common anatomical arch variant, that is the bovine origin of the left common carotid. In this, we did, it's called telescopic technique. Telescopic technique is a kind of technique in which we first form the scaffold via using the closed or open cell kind of stent within the parent vessel, and after the reconstruction of the major parent vessel, we deploy another stent, which is the membrane layer stent in second section or same section also, that is C-guard stent, to completely knock out that aneurysmal outpouching. This is the post 3-month post procedure angiogram, which revealed the well reconstructed parent vessel and completely obliterated the aneurysmal pouch from the circulation. Second case, 25-year-old female patient with the post-traumatic dissecting cervical IC aneurysm, which is even more larger than the previous one, incorporating the proximal cervical ICA and severely dysplastic parent vessel, having approximately 360-degree loop around the neck of the aneurysm. In this, we did same telescopic stenting. First, we form a scaffold via the closed cell type of stent, it's called wall stent, and straighten the parent vessel, and followed by we deployed another stent within the scaffold of the first stent, that is the C-guard stent, and subsequently did the balloon plasty also because of the tortuosity of the vessel. Stent, some part of the stent have a narrow segment, post check angiogram revealed, so we performed balloon angioplasty also. Subsequently, check run revealed complete obliteration of the aneurysm with well reconstructed parent vessel with good distal flow. This is the native image of post deployment of both the stent. After 3 months of the follow up, CT angio revealed well patent distal flow across that stent, and no residual feeling of the aneurysmal sac. Second scenario in fistula, called vertebrovenous fistula. This is the high flow shunt between the vertebral artery and adjacent vein, causing venous hypertension and the vertebral steal phenomena. Clinically presented as the pulsatile neck root, cervical pain, and the vertebrobasilar insufficiency, and the cardiac output overload in rare cases when the high flow type of VVF. The iatrogenic cause of this condition can be central venous catheterization and the cervical spine surgery, vertebral artery angiography, and the cervical trauma instrumentation. Treatment goal in this scenario is obliteration of the fistula site and the preservation of the vertebral artery if possible. Endovascular options like coil embolization at fistula site and the venous pouch, and cover stent across the fistula, the parent vertebral artery sacrifice if the dominant collateral vertebral artery present. representative case in this CCF scenario is 28-year-old female presented with post-traumatic neck swelling with syncopal attacks and the gait ataxia. CT angio performed, which revealed giant contrast filling aneurysmal pouch uh, with arterial feeder from the left vertebral artery, and also retrogradely feed via the contralateral vertebral artery. Diagnostic angiogram performed in the after the CT angio, and we planned to coil that dilated aneurysmal venous pouch and the fistula site. In this, we did it's called trapping technique. In this, we deploy the coils proximally as well as distally via the contralateral site, because if we do not sandwich distally, it will feel via the contralateral circulation. Diagnostic angiogram performed complete obliteration at first session, and we discharged this patient after 3 months with recurrent symptoms. She presented with us. Then we performed the diagnostic angiogram, which revealed the recurrent formation of VVF. In this time, feeders from the transverse C1 and C2 spinal arteries and the costocervical trunk and the contralateral vertebral artery also. So in this time we decided we fill the fistula site and the pouch via the embolizing material called onyx, and subsequently check angiogram revealed complete obliteration of the fistula site and the aneurysmal pouch of venous pouch. Third case in this scenario, 34-year-old male presented with iatrogenic post central venous catheterization subclavian artery pseudoaneurysm in the left side. This patient having both the side subclavian artery aneurysm. In this setting, we dealt with the left one first. Check angiogram performed shows the wide neck dissecting aneurysm incorporating the subclavian artery just distal to the origin of the left vertebral artery. Because of the origin of the various important vessel adjacent to the neck of the aneurysm, we decided that we put a close kind of the cell, that is the protege, and through the strut of the stent, we deployed various coils within the aneurysmal pouch. After 3 months, check angiogram revealed well patent parent vessel and no residual filling within the aneurysmal pouch. Last case of this discussion is a very life-saving procedure. One of the 6-year boy in the pediatric department presented with ulcerated large mass in the right periauricular region with massive bleed from the right ear and having difficulty in swallowing. Some attender told that the history of trauma, but we can't rule out the history of trauma or anything else. When he was presented in our department, he was intubated and managed conservatively with applied tight bandage and some blood transfusion also. We performed diagnostic angiogram, which revealed the giant cervical pseudoaneurysm incorporating the mid-cervical cervical artery with a very thin distal flow. This is the AP view, and this is the lateral view of that angiogram. In this, we did the same trapping technique. First, we deployed the coil at the distal end of the distal to the neck of the aneurysm within the parent vessel, and then subsequently the proximal part of the parent vessel. After deployment of the several coils, still filling of the aneurysmal sac was there. So we decided we inject some amount of the liquid embolizing agent also. Around 0.5 ml we injected onyx at the proximal part through the same coiling catheter. Check angiogram revealed complete obliteration, and this is the contralateral run, which shows the good collateral via the ACOM. The key teaching point in this presentation is the early recognition on angiography is life saving. This kind of the condition, balloon tamponade is the first reflex from any department, not from our side also. Always be prepared for the parent vessel sacrifice and the multidisciplinary coordination, involvement of the neurosurgery, neuroanesthesia, and ICU care also. Thank you.
Thank you, Suraj. Nice presentation, very comprehensive review of the very complex topic. But endovascular management is the way forward for most of these complex procedures, simply because they are minimally invasive and they can be done and the result can be achieved in quick possible time. So thank you very much. Okay.